Welcome to the EAU podcasts. In this episode, Professor Tagawa talks about the results on the Phase 3 PSMAddition trial and the potential clinical applications.
My name is Scott Tagawa. I'm a medical oncologist at Weill Cornell Medicine, New York Presbyterian Hospital, Meyer Cancer Center in New York, in the United States.
Can you give us a summary of what the PSMAddition trial is about and the key findings?
Yes, at ESMO 2025, I was fortunate enough to present the PSMA-Addition trial, which is a trial that utilizes the study drug lutetium PSMA-617, which is approved, at least in the United States, for patients with metastatic hormone-resistant prostate cancer after ADT ARPI and taxane chemotherapy, as well as in the post-ARPI setting prior to taxane chemotherapy, again for hormone-resistant disease. We wanted to study in the earlier patient population because we like to do that in general, but also because scientifically it's a patient population that we'd expect to have less likely AR loss and therefore PSMA low disease, as well as less likely to have inherent radioresistant clones. And it's a combination trial with two different hormonal drugs. The hormonal drugs may upregulate PSMA expression as well as radiosensitize at the same time. And so we wanted to move earlier as well as do it in a rational combination. The entry for the criteria was metastatic disease that was on CT, MRI, and bone scan. They had to have PSMA-positive disease. So every patient after signing consent went on to get a gallium PSMA-11 scan, and at least one of the lesions had to light up brighter than liver. And the patient had to be either naive to systemic therapy or just recently started with a maximum of 45 days of standard of care hormonal therapy prior to signing consent. Patients were randomized 1-to-1 to either standard of care ADT plus whatever ARPI was standard of care in that jurisdiction, and 1-to-1 to either that alone or lutetium PSMA-617 at the most conventional dose at 7.4 gigabecquerels at every 6 weeks times up to 6. Primary endpoint was radiographic progression-free survival, as measured by prostate cancer working group criteria for using CT and bone scan. And after radiographic progression was confirmed in the control arm, this is an open label study, they could cross over to receive lutetium PSMA-617. And in fact, about 60% of the patients that hit that criteria did cross over.
Lutetium PSMA-617 plus standard of care significantly improved radiographic progression-free survival compared to standard of care alone with an HR of 0.72. Does this result meet your expectations?
So the primary endpoint of the study was positive. It improved, as you mentioned, RPFS by 28%. The study was designed to show at least a 23.5% improvement. So the actual results did exceed it, and it was actually at the very first efficacy interim analysis. I would like to see more, but it did exceed the pre-planned threshold for significance. So, answer the question, yes, I would like to see more, but it is hopefully good enough to lead to approval.
Overall survival hasn't yet shown a significant difference between groups, although it's still early in the trial. What are your thoughts on that?
So overall survival actually looked better than I thought it would at this very early time point. So we know that all of the early events, whether it's progression or death, if it's due to cancer, are due to the most aggressive versions of the cancer. So it could change over time. Many trials will have the hazard ratio for overall survival with further time approach 1. But it is very early, and we know from the PSMA-4 trial, which was before it in an earlier hormone-resistant patient population, that with time, the hazard ratio actually improved overall survival. So we don't know what's going to happen. It may be that the curves are starting to separate for overall survival, and the hazard ratio is going to improve. It may be that's because of even more crossover in the future that it'll be close together. I don't think that we have to have overall survival, especially given the crossover, especially with the drug already proving overall survival in a different setting. So it would be great to have an overall survival benefit, but I don't think it's absolutely necessary given the crossover.
Regarding the side effects, many patients suffer from dry mouth with radioligand therapy. How do you manage this in clinical practice?
So the adverse events that we saw were more or less what we expected from the components of the trial. So there's ADT, there's ARPI, and then there's lutetium PSMA-617. So most targeted radionuclides do not cause dry mouth. This one does, likely because it's a small molecule that can get into all the areas of normal PSMA expression, including the products. So it's something we expect to see. It is kind of on the order of what I would expect to see in a phase 3 trial. So when we run a phase 1 or phase 2 trial in expert centers, we see a much higher incidence. So I think it's because the experts ask the questions in a very intense view. This is on the order of what we might expect in a randomized global phase 3 trial. It was the most common adverse event. Fortunately, 41 of the 46% that had dry mouth was grade 1, which was enough to comment on, but not enough to alter, to need to do anything significantly or to alter eating. But 5% was grade 2. Most of it did improve the time. You know, I don't know if the change, if it was grade 2 dry mouth or it was other adverse events or something totally different that affected the quality of life. We will hopefully be able to dissect that out. But that was the most common. The other ones that are common are GI in nature, and that's likely also based on the normal PSMA expression in the intestine. So nausea, vomiting, constipation, diarrhea, we see that with the PSMA small molecules. And then, the general constitutional adverse event of fatigue, that is probably the entire package, including the systemic administration of radiation. So what we'd expect, in answer to the question about what should we do in practice is, I think number one is counseling. So I think patients should be aware of the possibility of each one of these adverse events and either look to prevent or intervene early. So in terms of dry mouth, talking a lot right now, like I have a mild dry mouth, that happens sometimes. And if it's just that, it'll go away. But we would recommend good oral hygiene. I don't think that patients are necessarily required to see a dentist or a surgeon prior to start of the therapy, but having good oral hygiene to start is probably a good idea. And then mouth care that would include avoidance of certain things that may be damaging, such as alcohol-based mouthwashes, and go with more supportive tech care. Some people will use lozenges and other things. And then, prophylaxis in terms of, or at least early intervention for nausea would be another a good idea to do in terms of practice. The other adverse event that I haven't mentioned yet is low blood counts. So that could be anemia, thrombocytopenia, or neutropenia. Fortunately, none of them individually was higher than 5% in terms of a grade 3. But we should be aware of that. And we should know that the nadir is typically 3 to 4 weeks out. So we'll need to kind of monitor at that time point between the cycles.
So for that 5% of the patients that are grade 2 in terms of dry mouth, is oral hygiene sufficient or do they need other intervention?
Grade 2 means some sort of alteration in their intake or the need for an intervention. Usually any grade is worst at the first couple of weeks and gets better with time, but then can get worse again with the subsequent cycle. Yeah, most commonly we'll say some sort of oral rinses. For people that are more susceptible to that or it's happened before with the coming cycle, we'd say start ahead of time or continue the whole time. Other people just need to drink more sips of water.
Final question. Based on current data, do you see PSMAddition as a real game changer, or do we need to wait for overall survival results?
So this may be good enough to lead to at least US FDA approval, but that's not happening today or tomorrow. Could be in a year or a little bit more. We know in the press release from June 2nd that Novartis said that FDA suggested to submit for approval or label expansion by the end of the year. The end of the year is coming up, so it could be soon, or it could get into guidelines earlier because it's already an approved drug. So even if it's used off-label, if it's supporting the guidelines, that is reasonable. So I do think that the total amount of data, which is the multiple phase 2 and phase 3 randomized trials in the castration-resistant setting, as well as the phase 2 single-arm and randomized trials in the hormone-sensitive situation, overall, I think that the data are in favor of use. I think we need to use any drug wisely. So that would include, number one, patient selection, and one of the obvious also with PSMA PET. The other is to use it when we think that there is going to be the benefit, but then backing off, and this is no different than other drugs, when we think it may be too much. So that could be with chemotherapy, when someone has febrile neutropenia, we would back off, or with this particular drug, this is something where we can't actually visualize the target, and not everyone needs 6 cycles. So having a very good response, so that's going to include response to ADT and ARPI. So some people may need 2, some people may need 4, some people may need 6. I think it's something that we should keep in mind. And even though the trial was designed to administer 6 cycles, I don't think that everyone in practice necessarily needs all 6 cycles, at least not without a break.
Thank you for listening to this episode of EAU Podcast. To keep up to date with prostate cancer developments, visit our educational platform, EuroOnco Prostate Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.